Hey, what's up, everyone? Welcome back to Basically EMS. We're doing something a little bit different today, a little Basically ALS. And so we brought the big guns today. So we got Wade, as always. If you guys want to introduce yourselves and tell us a little bit about your background so people know kind of who you are and what you do.
Hey guys, Casey Lane. Been a medic going on 14 years. Been in the field for 17. Currently work as a flight medic and love every minute of it.
I'm Mike. I've been in EMS since 2016, a medic most of that time. I've been a flight paramedic for 2.5 years now. So, yeah.
Man, Casey, you've been doing this a little while. I didn't realize it's been that long.
It's
Not that much
daunting
older
to
than me.
do the math and I'm close to 2 decades.
Yeah.
Wow.
Yeah, that's probably almost like half your
right.
life.
Pretty
That's
close.
crazy.
Yeah.
Cool. So good experience is what we're saying. Yeah, coming from good experience. So, so we've been getting a lot of comments asking people about paramedic level stuff. And so, I mean, we are EMS educators, so we thought we'd kind of stay in our own lane a little bit and talk kind of more towards the school side of things. But we'll jump a little bit into some ALS stuff. For the first one, we're going to talk about some ACLS meds and a little pharmacology. So, let's jump into it. We're thinking atropine first. Sound good to you guys?
Yeah.
Cool.
Sounds good.
So, atropine is going to be a parasympatholytic, which is a lot of fancy things to say. Like it does what? What does that mean for you guys?
So if you break it down in your medical terminology here, parasympathetic, the parasympathetic nervous system, lytic is going to be, it works against stopping that parasympathetic response. So it's essentially blocking that parasympathetic response is a really basic way to
Mimetic
explain it.
makes it kind of go on steroids. Lytic kind of stops it.
Yep,
right?
exactly.
Yeah.
I like the second one, though, the anticholinergic, because that's something I feel like we don't talk about at the basic scope a lot is acetylcholine, for that parasympathetic. So the anticholinergic agent is how I always remembered it a little bit better. But definitely both apply, clearly.
Yeah.
So how about MOA? You guys got any good insight on the MOA and kind of how would you describe to somebody how this med works?
I think we just kind of did right there. It really just blocks that like the vagus nerve, right? Is like the main nerve of the parasympathetic nervous system, and so atropine really blocks that vagus response, which is what's going to cause the bradycardia or the slow heart rate in most patients that we're going to use atropine on. And it, we use it for other things. We're not going to probably go into that today. We're kind of sticking to the cardiac stuff. But when you have that really slow bradycardia, specifically a sinus bradycardia, if you look at the mechanism of action being a parasympatholytic, that's usually what causes sinus bradycardia. We don't use atropine with high degree blocks and that kind of thing because it simply doesn't work that way. And so knowing the MOA will lead you to why we use it. So I think it's really important with every drug is knowing that mechanism of action because you'll know why and when to use that drug.
What's your guys' success rate look like with using atropine?
Not much. Usually I will try it when I'm getting ready to do something more invasive like pacing.
Yeah.
Gotcha.
Or it's postcode and it's kind of just throwing everything at them. And I've had it work, but generally I'm using it as an adjunct before I'm doing something else.
Right. And I would say with sinus rhythms, sinus bradycardia rhythms specifically, I do have pretty good luck with it. Junctionals, depending on kind of where the signal's coming from in the junctional area, I've had kind of mixed luck. It was kind of like Mike was saying, it's a good bridge in a lot of cases, like before it kind of look at it like maybe a push dose epi
Gotcha.
Yeah, that's a good
type
way to say
thing
it.
where it's a bridge to potentially more invasive procedures. We had a good neurogenic shock not too long ago with the soft blood pressures and the bradycardia, and especially with a significant trauma mechanism where you're worried about bleeding and you're kind of in this gray area with the more complicated pressures and whatnot. The atropine actually helped quite a bit.
Yeah, because they've lost that sympathomimetic, that sympathetic response, right?
Parasympathetic tone.
So, yeah.
So it's more of like just a time buyer for I guess for you guys because you have longer transport times, right? So it's just in prep essentially.
Essentially, and I mean even in the ground shorter side, that is still gonna be a bridge. The getting them to the hospital, they're likely going to do more than just atropine. But for the paramedic on the rig, it's acting in the same way.
Gotcha. I've only ever used it one time, and it was a fast moment. And I once we got the rhythm sped up, and really looked at the strip, it turned out it was a 3rd degree. Whoops. But it did actually work pretty well. And the only thing that ended up biting me was that once we got him conscious enough, and then we got the 12-lead rip in, he was in a STEMI also. So it was a lot of whoopsie on that one, overworking that heart. But I had a good outcome, so I'm going to stick to that.
And that's a good point, too. Like, sorry, I didn't mean to cut you
go
off.
ahead. We're probably going to say
the same
thing.
It's a good point, too. There's been a lot of generalization with atropine and high-degree blocks. It's not necessarily that I hate putting the black and white term on it. It just doesn't work. A lot of it depends on where the signal is originating from. So it can have an effect in 3rd degree or 2nd degree even. There's some research to show it could potentially make it worse, but it just might be that more of that bridge to the pacing kind of a deal.
That makes sense.
And then on atropine as well, just because they're in a bradycardia doesn't necessarily mean we need to always treat it, right? So specifically like your STEMI or inferior STEMIs where they're going to have bradycardias, we don't necessarily want to give them a medication that's going to increase that heart rate a lot, right? Because of that myocardial oxygen demand. Sorry. That myocardial oxygen demand. So if they're sitting at 50, then they're perfusing well enough. There's not much we need to really necessarily do about that.
Right.
So this is something that I think a lot of paramedic students, they see, a slow heart rate, we need to treat that, right? Look at the whole patient picture.
Treat your patient, not your monitor.
Exactly. So I think it's important to recognize that threshold of when we need to give it and when we need to not give it, and that just takes a lot of time.
Yeah.
I think it's important to remember that the indication is not bradycardia. The indication is symptomatic bradycardia.
Symptomatic bradycardia.
Right, and that is a big distinction. And I very specifically remember an FTO as a medic, having, it wasn't VTAC with a pulse. It was like, I didn't even know, like some PVCs or something. And I was like, oh, cool, we're going to do like Lido, whatever. And my FTO was like, why?
Yeah.
Blood pressure's great, skin's great, everything looks good. Why are we going to introduce something that could have some side effects and whatever when we don't need to, right? And it's the same thing here. Yeah, people might just have a bradycardia, and if they're fine, we don't need to escalate things when we can't take that back.
And that goes for all bradycardias. I've seen people sit in 3rd degrees for days, weeks, and be perfectly fine.
I've sat there and watched it on the monitor, whole transport, just like, I'm waiting.
Yeah, with that patient I gave it to, it was a pass out situation because of it, and he was kind of in and out of that somnolent, and it was one of those I'm just looking at the monitor, should have printed the strip, but that was okay, I'm symptomatic enough I could justify it. It wasn't until I got the bigger picture. So pro tip, get all of your information in front of you first. Goes a long way.
So bradycardias for this, how I remembered this for bradycardias back in the day is I remembered it as Atropine. I don't know. It just stuck in my head, right? It's like Atropine summer. And so that is how I made the distinction between
whatever works.
Yeah, right? Yeah. If it's stupid and it works.
Yeah.
That's how I was able to make the distinction between adenosine, atropine, because I know as a student that was really confusing.
Yeah.
And we were kind of talking about before what the meds we're going to talk about in what order, and to me those kind of are kind of diametric sister medications in a way of this is for too fast, this is for too slow, here's your basic meds. And so I always got it confused, and I just remembered, Atropine is just slow, right? So whatever works to make you remember, but that was my thing for the most common indication for atropine is going to be that symptomatic bradycardia.
Yeah. And on meds in general, this might be a good point, near the beginning of how do we all study to memorize our pharmacology. I know what I did in paramedic school was I take these pharmacology sheets, basically. I take a whiteboard, and I would just write it all out. And then when I was done, I would erase it and then write it all out again and just do it, because I think pharmacology compared to your pathophysiology and your, all these other things, it's a lot more just straight up memorization. There's really not a whole lot. You can probably teach yourself all sorts of little songs and little mnemonics and whatnot, but it just comes down to strict memorization, and it's just putting in the effort.
Yeah, with cardiology, I have an active picture in my head of the heart, and when I look at a 12 lead, it's it spins to the.
It's like a beautiful mind,
right? to the section
Rain
that I'm
Man,
looking
actually.
at the 12 lead, but you're right with pharmacology, they're just not really a similar mechanism there.
Yeah.
And it was, for me, it was just reading these things until blue in the face. you know?
Yeah.
There's a difference between learning concepts and learning information.
Right.
And this is learning information, right? Like this is stuff that, I did the exact same thing. And my poor wife, right? Like I had my note cards and I had my whiteboard and I would do it forever. And I'd give her like my note card with that medication and be like quiz me, right?
And, yep.
She could have passed my pharmacology exams because she knew it so well because I just spent so much time.
Yeah.
Because I don't know about your guys' program or if you're listening to this not in paramedic school, my program, 5 meds a week for a section, and it was a blank page.
And early too.
Early in
Like,
the
okay,
program, yeah.
yep.
Essentially a blank page. It said, the top would say atropine, and then you better fill out everything you know about atropine there, and that was our pharmacology exam.
Right.
And so it was hard. And doing 5 medications a week, and you still need to remember what you learned 3 weeks ago.
Right.
As far as that goes. So, yeah, this is definitely something. If you're a new medic student, you need to put your time in. And the whiteboard to me is just for memorization is my go-to.
Perfect.
Yeah,
I
for
still
sure.
use it on stuff these days. Yeah.
That was the best method. I also recorded myself just talking about them. So like when I was mowing the lawn or if I'm just doing something, it was just passively in
that's
the
a good one,
background.
too.
Granted, you get used to hating the sound of your own voice over time, right? But like
Is that where you perfected that radio voice? Yeah.
Yeah.
radio voice. Yeah.
That's a good point too. I don't do this. I slept through a large chunk of paramedic school. I was working nights at the ED, and you get off and you go straight to school. And I slept a good chunk of paramedic school. But I did have a recorder that was always on. When the teacher was giving the lecture, professor was giving a lecture. And same thing. When I'd go to work the next night, when I could, I'd pop in my earphones and listen, or mow the lawn or whatever. So all kinds of little tricks.
Yeah. Yeah, it's you got a year or whatever. Just do it for a year. It sucks. Get it done.
You can do anything
Every
for a
day.
year.
Yep.
Yeah.
It's all about survival.
So another thing for atropine is going to be like organophosphate poisonings, right?
Yeah.
So that's another common thing that we're going to give this for. So duodotes, I think, are atropine, right? Do I have that confused with a different? There's like a special med that we carry just for like organophosphate poisoning. Maybe I have that
The
backwards.
duodote, I believe, it's a 2-PAM chloride.
Yeah, 2-PAM. Yeah.
Yep. And then atropine is just
Separate.
in that, right? It's the A and PAM, right?
I should have looked this up before. Obviously we don't use it very often,
Yeah.
right?
Yeah,
I usually go straight to just atropine if that.
Yeah.
And those require so much atropine. I mean,
So
I don't know.
much,
We carry maybe 5 milligrams on a rig, maybe.
Maybe, yeah.
If we're
Hardly
lucky.
anybody carries enough for a
And
true.
you're going to need 5 to 10 minimum.
Yeah.
So-
Which kind of leads us in for dosaging. So dosaging is going to be a little bit harder. The EMT stuff is really easy because it's pretty standard dosaging across the board of
Right.
like nitro 0.4 pretty much anywhere you go. But paramedic stuff can definitely be different. So if you're listening to this, you're watching this, make sure that you're not necessarily just going off what we're saying for dosaging. Like
All your local protocols.
Yeah, look at your local protocols or whatever. I mean, from what I remember for National Registry, either it was something that had a really strict like 1 milligram of epi and cardiac arrest kind of a thing, or there just wasn't really dosaging questions. So I don't know if you guys. I mean, yours was a long time ago. Mine wasn't. Mine was like 11 years ago, so not that much. A long time ago too.
It's still a long time
Filled
ago.
it out
Yeah.
in like stone.
Smoke signals. Yeah, smoke signals. But so I could be wrong, but I'm pretty sure that's how National Registry typically goes for dosaging. So not something I think we need to delve too much into here.
Yeah.
Especially meds that are also considered, on the ACLS algorithm. Yeah, most of those are going to be pretty standard dosing.
Yeah. And so for this one, we have, I don't even remember what we got. There we go.
0.5 to 1.
0.5 to 1, yeah. I think is the pretty standard dosaging. So,
Milligrams.
Milligrams.
yes,
Yeah.
thank you.
The units of measurement afterwards are important.
Yes.
For you guys, for those kind of meds, do you have anything in your head of like when it gives a range like that of what gets 0.5 milligrams versus 1 milligram, or is there anything that leads you one way or the other as medics?
I usually just give 1 personally,
'Cause
but
it's easy.
it's easy.
Whatever the easier dosaging is.
Yeah.
And I usually give the 0.5 just to see what kind of response I get. It kind of depends on how certain I am. And this, I understand that this statement takes experience, but it kind of depends on how positive I am it's going to work. Usually it's 0.5, and then if I need to, I can give more.
So almost like a 0.5 is not necessarily a diagnostic tool, but kind of almost a diagnostic tool.
Kind of almost.
Yeah. I mean, which is fair.
Trial. Yeah.
Yeah. You know, to see if you're in the right line.
Right.
I mean,
am I totally sure there's no other cardiac issues going on, no STEMI, no NSTEMI? Is this just simply sinus bradycardia symptomatic? If it is, then, I might lean towards the 1. If I'm not 100% sure, probably go towards the 0.5 and just see what kind of effect I get.
cool. Yeah, I think that's fair.
And it has a relatively quick half-life on it too.
Right.
So
Yeah, one thing about this I was really surprised the first time I gave it was how quick the onset was. I mean, it was not
fast.
quite immediate, but like 5-10 seconds of
pretty quick.
watching that heart rate really bump on up.
Do you want to talk about contraindications at all?
Yeah, for sure. So contraindications, Wade, what we got?
Well, there's a list, but I think
There always is.
Looking at the big one, I think AFib, A-flutter is
Yeah.
one that definitely needs to be, considered.
Yep.
Just, like Casey was talking about, where in the heart is the conduction going on? Is this really going to make a difference or not?
Yeah.
And then do we run the risk of throwing him into something like AFib with RVR or, doing more damage?
Yeah, because if you think about if the atria are firing at that rate of AFib, which is fast potentially, then you take away that conduction delay or that conduction issue, then you're going to get a ventricular response that's going to be way faster than
You're
you want.
knocking out your middleman,
Yep.
your regulator, yeah.
That's a good way to think of it. The middleman, I like
Yeah.
that.
Yeah, and then myasthenia gravis is another one on here. So, maybe be thorough about asking those kind of things, or, those are hard sometimes with how specific at the medic level that some of the contraindications can be.
A lot of these contraindications for a lot of these meds, it's borderline unrealistic to think that we could, depending on the situation, unrealistic that we could deduce those kinds of contraindications.
Yeah.
Like if you're at a point where you're given dopamine,
Yeah.
you're not going to know if they have a pheochromocytoma. Like, right. You know what I mean? Like a lot of these are I'm not saying they're wrong, but they might be a smidge unrealistic for a paramedic to realize.
So good test question knowledge, maybe not real life knowledge, because we're probably just not going to see those two very specific, uncommon things happen at the same time, essentially.
Yeah.
Yeah, and so especially with something like myasthenia gravis, it's hard to find because it's a neurologic condition. So they may not even be aware. They just might be like, I don't know, feel a little bit weak, a little tired, whatever.
Yeah, it can take years and multiple doctors to diagnose that. Like,
Yep.
Side effects are going to be those anticholinergic effects, right? So, just I think you were kind of talking about, right, like the sympatholytic kind of a thing, and kind of falls into that, right? So, dry as a bone, mad as a hatter, red as a beet, and blind as a bat, right? So, you can see those kind of things, especially if you're given a little more than you should, or something along those lines.
and to that point with the anticholinergic stuff, that's what you're looking for, right?
Yeah.
They should be giving you sludge symptoms, salivation, lacrimation, urination, defecation, and emesis. You want to dry all that stuff up, so you're looking for all that stuff.
Yep.
Yeah, for the organophosphate stuff.
For the
directly.
organophosphate, yeah.
You guys got anything else on atropine?
I do not.
I don't think so.
I just remember with atropine, there are more uses for than what we're just talking about. So make sure you're checking your protocols wherever you're at.
Yep.
And double check the sheets. The national sheets don't always line up with your protocols. That was something I ran into, at the agency we worked at. It deviated slightly, just depending on the circumstance. So just pay attention to it.
Yeah. Yeah, and also kind of flip side of that, because the agency got hired at, it's a different state than where I did my medic school, and so flip side, if you are testing, not a bad idea if you can to find those protocols and kind of see what there's protocol state too, because I know that was a lot of my prep for testing for the agency I got hired at, was like going through and seeing what dosages were and indications were, because I didn't want to give something where they would be like, well, dude, what are you doing? Right. Like, because this is definitely at the medic scope, there's definitely off-brand uses that are going to be in your protocol book and that kind of thing, that we're going to go outside of the normal ACLS scope of stuff, and maybe dosaging might be different too. So,
Yeah.
Not a bad idea to look at that, because where I came from, where I worked, adenosine was a weight-based. Atropine was a weight-based medication. I don't remember what it was. It was very complex.
Right. Interesting.
But it was weight-based. I remember coming up here and be like, sweet, this is so easy. I don't, no math. Yeah. Make sure, know that, know the standard stuff. But if you're going to get hired, not a bad idea to come in prepared for that as well, because it might be different too.
Yeah.
Yep.
So next, let's talk about adenosine. Or do you guys adenosine or adenosine? What have we got at the table? I've heard
Adenosine.
both.
Adenosine.
There's enough Zens out there.
Yeah, that was always adenosine. It was always weird to me, but
Yeah.
I'm sure you guys have heard it, right? I'm not crazy. I've heard plenty of people call it adenosine.
Sometimes
heard
I
that,
probably
yeah.
called
Okay.
it on
It's
accident,
wrong.
but,
That's totally wrong. Just call it adenocard.
Yeah, just to
be
Yeah.
different.
Yeah.
Okay. So this is going to be a supraventricular anti. Man, somebody else say it, because I can't say it.
Supraventricular antiarrhythmic.
Thank you. Yeah. And so this is going to be something that we're going to use for fast heart rates, right? Kind of the flip side of slow heart rates. Adenosine is going to be used for fast heart rates.
Right.
So what does it do, guys? What does it do for the body?
Well, one, we make it naturally, right? ATP, so that's something worth considering. Adenosine triphosphate, for those who don't know. But it slows down that SVT, right? Essentially, I always thought about it as like unplugging the computer and plugging it back in.
Yeah,
Give it a
totally.
hard stop.
That is your hard
Yeah.
reboot. Yep.
Yeah.
Primarily is going to act on your AV node. It does hit the sinus node a little bit. I think the big thing to remember, and apologies, is a smidge of a pet peeve of mine. Just because it's fast and it's narrow doesn't mean it's... This is a weird thing to say. It doesn't mean it's SVT. It is SVT because it's above the ventricles and it's tachycardic. But SVT is when you don't know, you can't tell where the origin is coming from, right? So you see these rates of 130, 140, 150. Those are likely not SVTs. I know it's fast and I know it's narrow. It might be hard to maybe identify a P wave, but those are likely not. There's another name for those, right? You should be able to tell where those are originating from.
I mean,
Yeah.
by definition, I think SVT is above 180 or 160, I think, depending on the literature. you
Yeah, I
use.
thought it was
160.
150 was what I remember.
somewhere in that range. I don't even think it twice until it's 160.
Right.
So,
Yeah, and I've heard anywhere between 160 and 180. I think people shy away from the 150 side just because that seems to be the inherent rate for 2 to 1A flutter, which also is narrow, fast, and pretty regular. I've heard 160 to 180. It's also pretty easy to perfuse pretty well at the 160. When you start getting faster than that, that's like when you kind of got to take your next steps and fix the problem.
Yeah, like 160 is normal working out heart rates, right?
Right.
Yeah. The body should be able to manage that for a fairly long period of time, where 210 is a whole different story for sure.
Yeah.
100%.
Yeah, so I think that's a good thing. Yeah, this is a blanket term. Even at 210, it could be, there is a different name for it, but we can't tell. And so this is a blanket term of, it's a fast heart rate above the ventricles. We don't know what it is. That's what SVT is.
Yep.
So
But there are specifics.
Go ahead. So for identification, would you just have them vagal to slow down to double check that SVT? Is that kind of your thought process? It's because until you can identify the P waves, like because it's going fast, so it could be tough, right?
Yeah, and I've not had, in the pre-hospital world, I've not had great luck with our traditional vagal maneuvers. You can get pretty in depth on your vagal maneuver procedures, and back when I was working at the hospital, they would do the 3-step, dunk your face in water, blow through a straw, while all at the same time putting you in like Trendelenburg type deal. And I saw more of those actually work and convert. You might get a little bit of slowing with our bear down trick or blow through this 20 gauge catheter. But more times than not, I'll try that, usually as a bridge with the strong suspicion that it's not going to work and that I'm going to end up giving a med.
I agree. I don't think I've had much luck with vagal maneuvers. Maybe once or twice where it's worked. Adenosine's actually something I've given a fair amount to, and usually I'll try the vagal maneuver as I'm getting everything kind of ready to go, and as I'm getting my pads ready, because a lot of times adenosine doesn't work either. I mean, I've had it work a few times, but there's been a few times where it definitely doesn't work either. You just have to be ready. So just be ready for
And that's
that
a huge
progression.
pro tip. Like, yeah, these are meds that can have adverse effects. Like, be ready for the worst. Put your pads on before you do the hard reboot of the heart.
Absolutely. You know? And then don't hold your breath for too long watching that heart kind of flatline for a second. Yeah.
Guys, it's been 10 seconds. Do you think it's coming back?
Like, what's your threshold of when we do something, right? Yeah. So that kind of probably brings up a good point of, what to kind of the practical side of adenosine, right? Yeah. How does it look? How do you push it? I mean, I know I used to do the whole, like, hang a bag and do the, one flush here, one flush up higher, and I pushed my adenosine here and have my partner push the flush. There's been some research out there that shows you can draw it all up into a 20 cc syringe and just push it all at once. And everybody's going to have super strong opinions on this no matter where you go, and everybody's going to tell you you're wrong no matter what way you do it. But the way I do it now is I'll hang a bag, I'll draw up my adenosine now with a 20 cc flush all in one and just push it all at the most proximal line of your IV, and then I'll follow it with a flush from the bag.
Gotcha.
That's a really easy way that I've done it lately, and it's been pretty effective.
You don't want to play with the three-way stopcock anymore?
You can do it, but I mean...
So I still use the three-way stopcock every now and then.
Yeah.
We did last week, and the adenosine didn't work, but
Yeah, same with me.
That would be my advice is pick a method, practice it. If you have a partner and it requires a second, whatever your process is, requires a second set of hands.
Yeah.
Make sure you are good enough at it that you can teach it and explain it to somebody that may have never done it before.
Exactly. That's a really good point because, you never know who you're going to be working with. And like I said, everybody does it a little bit of a different way. So you need to be able to explain it to somebody, especially with adenosine, because such a specific, you need that bolus of adenosine for it to actually work. Because the half-life is so short. Unlike, an atropine or a lot of our other meds that we give, the adenosine needs to be given super fast. And so that's really important with a good IV. Make sure you have a good IV.
Yeah, I learned that lesson on a call. First time I ever pushed adenosine was actually out of a jail. And the patient, we showed up and they had an IV established already, and we didn't notice his arm was kinked. So we pushed the first dose of 6, nothing happened, pushed 12, and we were like, hey, your arm's bent. And so we straightened it and pushed the 12. And then when 18 inevitably hit that person, went from like 200 to like 40. And it's like, no, you got to get excited, buddy. And then it didn't work. And then away we went, But yeah, it can definitely be scary when it slows that rate that quick.
Yeah. And then just a little pro tip for your documentation. Make sure you're hitting that little snapshot button on your monitor or printing out your strip as you're seeing changes. So you definitely want to document your changes and keep an eye on your monitor for a while. It's going to cause potentially a little bit of asystole. It's going to cause some really funky bradycardias. That's expected with adenosine. It's going to happen for that 10, 15, maybe even 30 seconds. And then also watch for, just because you fixed it doesn't mean it's going to stay fixed. Most of the time when I give it, it'll work for a little while, and then they're tachycardic 2 minutes later.
So you're not treating the underlying problem.
Right.
Whatever it is that causes
most likely not.
tachycardia, you're probably not fixing that, so they'll probably go back.
That's likely going to need an ablation.
So for you guys, because you give it more frequently, have you noticed that like your conversion rate with 6 or 12 is better?
12.
And I'm probably 50-50.
Or nothing.
The second 12, I rarely give that. And it kind of depends on what happens when I give the first 2 doses. Did it break and then go back? Then I might push it again. Did it do absolutely nothing? If it did nothing, I'm probably not pushing that second 12. There's something else going on.
I feel the same way, and especially if they're even on that borderline of stable, unstable, I'm going to electricity in general. I just think electricity has been super effective with cardioversion.
I think one thing also that people don't talk about in medic school about adenosine is that you're going to get a painful patient response from time to time with it. They don't really mention that, until you see it push and they're like, oh, I just got kicked by something,
Yeah.
And that's,
explain it to your patients what's going to happen, because they're going to be really pissed off if you give them a med and it makes them feel like that. So.
And that goes for the shocking or the med. They're going to feel like just straight garbage either way. Just prepare them for it. It's good patient advocacy.
I had a patient, one of the patients I did give adenosine, it did not work, was with a paramedic that I went to paramedic school with, and she did not do a good job of explaining what was going to happen to this patient and started charging the monitor and the I always explained to her like, hey, this is really gonna hurt, and it converted her out of the rhythm. I think just of her being scared of like the monitor charging and that kind of thing. And she stayed out of the rhythm just from, I mean, it was almost like a vagal response, I think, from being so scared about what was going to happen. But you just do a good job of explaining to your patients what you're doing.
Fear's the new treatment option.
Yeah.
Yeah, just Mike standing over you is just enough.
I'm just sitting there like, this is going to hurt.
Contraindications. What about contraindications for this? Anything jump out to you guys as like real life? This is really something that we would come up against and we need to be aware of.
WPW, don't you have a
WPW is one, and that's another one where it's not necessarily going to be harmful. It's just not. It's kind of a waste of time. It's not going to do anything, right?
Underlying problem.
That's WPW is essentially it's a extra wire that's skipping that AV junction altogether. So you're just likely not going to get any result out of it, good, bad, or indifferent. Another one of my pet peeves about a lot of these contraindications are they're kind of like very, very common sense, right? We know we give this med to slow down rhythms, and one of your contraindications on here is going to be don't give it for bradycardic rhythms. Right? Like,
and
hopefully people put that together.
it's the lowest common denominator.
It is. You're totally right. But
yeah, and I think sometimes they're relative contraindications too. You can almost talk yourself out of giving any sort of medication,
Totally
right?
true.
And so I think you need to really looking at your patient. If they need a treatment, do it. You can talk yourself in or out of about anything, but if there's indications to give a medication, just do it.
Right.
I mean, if they need it, give it.
I think that's where knowing the MOA a little bit comes into it of like, if you know what what it actually does in the body, then it's a lot easier to make a determination, right? If you're just cookbook medicine, right, following indications, contraindications as little line items, then it's going to be a little bit harder. But if you understand what's going on, like you should understand not just what the contraindications are and indications, but the whys.
Yes.
And then it's a little bit easier to navigate of like, when am I going to do this? Or even just the electricity versus medicine. Like drawing that line's a little bit easier when you understand like behind just the simple drug sheet.
100%. Yeah.
And we're all going to be cookbook medics probably for the start of our careers, and that's totally fine. We need to be a cookbook medic before we can graduate to, someone that's got some critical thinking and is able to kind of work through those calls. But it's okay to be a cookbook medic for a while, but you need to graduate at some point.
You kind of need to be, for sure.
Yes. At minimum, you need to be.
At minimum, you need to be. And there's for a long time in the paramedic realm, there's been this, stigma that we are trained, not educated.
Yeah.
To your point, knowing the backside mechanism of these kinds of things, it's pushing us towards the education side, not just the training side.
Yeah.
It's not just give adenosine for something that's fast. Here's your doses.
Right.
This is why not. It's definitely pushing us in the right direction.
Yeah, and I think you guys are a great example sitting here of like, kind of the top echelon of what people can and want to do in this field of like, flight medicine's kind of it, right? Like there's not, at least unless you're going to go get a higher certification level, like, whatever.
Right.
That's kind of with your paramedic specifically, flight medicine is going to be it. So
it's one of your ceilings. Yeah.
Yeah, exactly. So if you're listening to this and you're like, I want to be a flight medic, like that's some good advice for you to really think about what you guys are saying and where you guys have been at with this of like, education versus training and actually understanding like the why, not just doing as you're told.
Yeah.
It's very conceptual at the flight level. It's not see this, do that. It's very much you need to know the why. So it doesn't stop when you're out of paramedic school. It just continues and builds and builds. So,
and a little bit off topic, but like to getting into the flight thing, was that something? Because I'm sure that there's pretty rigorous testing. Like, is that something that you think was evaluated, or maybe you guys have been on the other side of the interview table, or whatever? Is that kind of thought evaluated, and are you given scenarios? Maybe you have to think a little bit more through it and can't just cookbook your way through it. You have to have some good knowledge of what we're doing.
I think so. At least with my testing, I've tested for 2 different flight companies and worked for 2 different flight companies, and I feel like they're bigger on, are you going to be a really good team player, and are you going to be a critical thinker, as far as safety as well. But yeah, when they talk about a lot of the clinical testing when it goes into flight, they want to see not only do you know the basics and the meat and potatoes of being a paramedic, but they want to know that have you mastered being a paramedic and the critical thinking side of it, because that's kind of what it takes to progress into the critical care side.
Yeah.
So,
and for me, it was I didn't get tested on a lot of that stuff. The assumption was kind of, you've been a medic for this long, you should be dialed here.
Yeah.
Most of my testing was nurse-related stuff, and then for the nurses, vice versa. A lot of their testing was medic stuff. And, but, knowing this kind of thing and being able to, explain it in some of my scenarios and such, that is what got me, FTO relatively quickly in my flight world. But yeah.
And knowing, and they want to see your humility too, right?
Totally.
Understanding you, if you're new to a flight job and you're trying to talk about, Casey and I had this tocolytics I never knew what that word
That's
was
a
going
word.
into a flight.
Sure.
And they ask you about that kind of stuff, and he told me about it. I remember when I was prepping for my first flight interview.
Yeah.
And he's like, yeah, can you tell me about tocolytics? And I'm like, toco what? And so it's just.
And I said, say that.
Yeah.
Say that exactly.
And so, yeah, and seriously, what they do is they're going to ask you stuff above your scope, and they want you to, if you know about it, sure, talk about it. But if you don't know, it's knowing your resources really well of how you are going to find that answer. It's leaning on your nurse partner. Hopefully they know what a tocolytic is. But, it's going to be leaning on your protocols and partners and physicians and that kind of thing. So I think that's a bigger part of getting into the flight world is understanding your weaknesses and building on those.
Yeah. Being dialed in your strengths and then understanding your weaknesses and building. Yeah, for sure.
Yeah.
I think it's interesting they crisscross that, because I can see why the understanding of the other person's scope would help so much.
Totally.
It makes total sense. That's crazy.
It makes an extremely good balance for scope. Yeah.
So do you notice a natural pairing almost with these people? Besides human-to-human rapport, right? That's going to be different depending on the person. But as far as call fluidity, does it help?
Especially if you work together before, it can be really it's two very different worlds combining, and if you don't work well as a team, it doesn't go very well. But if you're a good team player, which most people are by the time we get to this level, we kind of understand what needs to happen, it can be perfect.
Yeah.
Yeah.
And yeah, me and my partner, shout out Holly, she's great, and we've developed just this pretty, amazing flow that just makes everything go super smooth. We have to be, if we want to challenge ourselves and it's an appropriate patient to do so, we have to be conscious about, she needs to come to me and say, hey, do you mind if I get this tube? I think this would be a good one for me. If it's that super sick that needs to be taken care of right away, we kind of just jump into our natural roles. Or if we have a bad ICU patient, I need to be, somebody on 10 drips. I know I can fumble through it, but I need to have it in my head. I need to say, Holly, hey, will you take the cardiac stuff? Will you let me do that? Otherwise, we just kind of fall into our natural roles, and it flows really well.
Cool. Yeah. A little off topic, but one thing you guys said earlier that I think is really important for students to hear especially is the use of resources should be a lot of what you're learning to do.
Totally.
Right? And I know from my experience, going through paramedic school, starting in FTO, I felt like I had to have all this memorized all the time and all that. And I mean, there's going to be a level where you have to, right? But
there is a certain level, that
but,
needs to be memorized.
Yeah, for sure. But I mean, I feel like being good at this job in a lot of ways is recognizing when you need a resource and knowing what resource it is and going and getting that. And so, we're talking about, these meds, and maybe you're going to have to look something up, or maybe, a patient tells you they have WPW and you're like, what is that?
Right.
It's okay to use your resources, and having the humility, like you said, to use them, I think is really important, which is really hard. Going through paramedic school, it just feels like that's not allowed.
Yeah.
Right.
Yeah.
And then in real life, I mean, there's a library in the ER for a reason, right?
Yep.
Even doctors have to use resources. So.
And I mean, to that point, I'm so glad I started off my career in hospital as an ED tech, because the best ER doctors that I've ever seen, ever had the opportunity to work with, they are calling for consults constantly, right? And it's not that they're dumb. They know their stuff. They're extremely intelligent. But they know when something is outside of their lane. And yeah, that was huge in me learning to put my ego aside and call for help when I needed it.
Yeah.
Yeah.
All right, way off track. Let's get back on track. Are you guys all good with adenosine? Anything you
Yeah, I
want
think
to
so.
talk about? All right, cool.
Can I add a fun fact about adenosine?
Yes, of course.
In the cath lab, they push it as a microdose vessel dilator to check for flow in the coronary arteries.
Interesting.
I've seen that.
It's kind of fun.
It is interesting.
You know, you learn something.
my pay grade.
Learn something new every day. Yeah, I mean these guys are above our pay grade, and they're like way above their pay grade. So that's stages above our pay grade for sure. You guys, amiodarone next.
Amiodarone.
Making sure we have the sheets in the right order here. So amio is going to be an antidysrhythmic, and I feel like you guys probably have a little more insight into that because I know this is, especially Casey, I think this is a little more your realm of knowledge that you really enjoy, right?
I mean,
Casey's
as much
a
as
cardiac guy.
as much as one can enjoy pharmacology.
So tell us about
Talk amiodarone
amio,
to me.
what it does.
So amio is an interesting med. It is your it's another anti-tachycardic dysrhythmia med. Did I say that right? That was a lot of jumbled words. Yeah,
Close enough.
We'll call it an anti-dysrhythmic. Amio is kind of an everything blocker, right? It's kind of a shotgun from the hip, spray and pray, if you will. Just kind of hits everything, which is not necessarily a bad thing, especially when you don't quite know what's going on. There's a few contraindications to it, a few precautions and relative contraindications, just like every other med. So kind of up to you. Whether you want to use it or not. I'm not a huge fan of it. I think it has its place. I've seen it work. I've seen it not work. The big thing for me is it because it is an everything blocker. It also has the giganticest. It's a new word. Giganticest.
We're educated.
Half-life.
Yeah, it does.
It lasts forever. It lasts for more than a month.
Whoa.
Yeah.
Oh, really? I didn't realize
It's
that.
like 45 days.
Wow.
It's probably the biggest reason I think to not give it, honestly,
Right.
in a lot of situations is that half-life.
Yeah.
So because your toolbox is much larger in the sky than it is on the ground, has your opinion on amio, did you have the same opinion on the ground, or has this changed once you got into the flight because you realize that I don't need to use a shotgun, I can use something that's more specific now that I have that tool to use?
I'll say that it's been more cemented
Okay.
with the toolbox. I think, and I was actually trying to differentiate this the other day. My paramedic school instructor is one of the old crusties that have been doing it for longer than I've been alive, you know, and he was the old school type who just pushed Lido. He hated amio. And so I was trying to differentiate when and / if my bias from him was what was driving this we'll call it discontent of amiodarone versus Lido. I think there was certainly an element of bias, but then after using it a few different times and not quite getting the results I wanted, that was when I kind of started forming my own opinion, using Lido a little bit more, seeing the results from it. And that's not to discredit amio. It does work. It does have its place, for sure. But yeah, if anything, to answer your question, it just cemented it a little bit more.
Yeah, and I think one thing is we sometimes have more of the answers when we have a patient initially, too, especially if they're coming from a hospital, so we can be more specific in what we use, whereas on the ground, I've used amiodarone a lot more, honestly, on the ground because of just cardiac arrest situations.
Right.
Than anything, but and we've all pushed amiodarone a ton because of that exact situation. But yeah, I mean, it just shows that it's not just something just to give because you see this, you know, right? You just need to be a little bit more cerebral about why you're pushing a different medication. So knowing that it blocks the sodium channel blockers and calcium channel blockers, and so
Beta
why do we
blocker.
not? Yeah, beta blocker as well.
Magnesium channel blocker, yeah.
Yeah, that exactly. Like, there's going to be times where it may not work, right? So we look at, contraindications of it, or indications being, pulseless VTAC, VFib, and VTAC with a pulse. And the contraindications, right? TCA overdoses, Benadryl overdoses. Those are the times where it's actually important to know the why, because a TCA and a Benadryl overdose, they widen that QRS. It's a sodium channel blocker. And so if you give amiodarone, which on top of that is a sodium channel blocker, it's just going to widen everything, widen that QT. So that's not what we want in those situations. And so that's where it becomes really important with amiodarone specifically, of knowing the mechanism of action.
Yeah. Mm-hmm. And to that point, I mean, with the TCA overdoses, for example, or maybe even like a hyperkalemia with some really fast, wide complexes, it can be relatively easy to just look at that, oh, crap, VTAC, push the amio. I would encourage every medic, every paramedic instructor, every student to go check out a quick video by Dr. Amalmatu. It's on YouTube. It's called How to Avoid a Clean Kill with Wide Complex Tachycardias.
I've seen that like 5 times.
I think I watched it because you told me to.
It's a good video.
I showed it to every one of my students. I try and pass it around. It's a great video. He does an amazing job at kind of dumbing it down. But, he talks very much to Mike's point about take a second, kind of work through the problem, try and see if you can figure out where this is coming. If you see this or this, maybe just think about going with your bicarb and your calcium first before you kill this patient. If it doesn't work, then move on down to your amio, your lidocaine, your procainamide, whatever. But yeah, maybe we can put the link to that up on the screen or something.
And generally, they're talking about like slower, wide complex tachycardias, right? As like a simplified explanation of that video, basically.
If it's over one big box wide, if it's 130 to 100, those just aren't the fitting criteria for VTAC. So maybe think about like this empirical use of calcium or bicarb. If it doesn't work, it doesn't work. Move on down the algorithm.
Yeah.
But I remember talking about this with you. I think it was when we were getting vaccinated, 2020. But it was I wanted to push calcium so bad after that, because you're like, yeah, it works, and I'm like, I need it, and I never got the chance. Never had that one. But yeah, it was a really good video. I remember that one.
It's a good video.
Yeah.
So what are the use cases for you guys for amio though? And is it like cardiac arrest would be kind of what you're really thinking, or when would you maybe fall into amio as opposed to something else?
I mostly have used it in cardiac arrest. And if you convert them from amiodarone to cardiac arrest, setting up that maintenance infusion, that's kind of where I stick to amiodarone. Right. If it's VTAC with the pulse, and because of a call I ran with Casey when I was brand spanking new, I was like, I'm not doing amiodarone with VTAC and a pulse because of the equipment we carried at the time. I think was the bigger thing. Yeah. I was a paramedic student at the time, and Casey is like the cardiac guy, and so I was super nervous to work with him. But I walked in, he's like, I'll let you run this one.
I never could tell.
Yeah.
You're so smooth.
I walked in, I was like, he's like, you can run this one. The guy's sitting in his wheelchair in his house, and I just remember starting the assessment, feeling his pulse. I'm like, it's a little fast, nothing crazy. And then Casey's putting on the 4 lead, and Casey like turns around, he like claps his hand, he goes, we got VTAC. And the whole call chain, he took over from there. But yeah, it was pretty funny. But
that was involuntary takeover.
It
just came out. I'm sorry.
Yeah, that's fine. It was one of those moments. But and we fumbled around with amiodarone for the entire transport, getting it set up. But I think we used Lido as well because we couldn't figure out the amiodarone. But
if I'm remembering correctly, again, follow your local protocols. We ended up just slow pushing it.
You're probably right.
Rather
yeah,
than the
actually,
infusion.
Yeah.
Which I was nervous the entire time doing that. Amio is definitely one of those things. Unless they are coated, this is not a push drug. This is an infusion drug. Can have definitely some detrimental side effects if you push it too fast.
Yeah.
If they're already dead, they're not going to get any deader.
Right.
So yeah, that was a fun one actually.
That was a long time ago.
Yeah, but to your question, I'll admit that the dosing and the resultant infusion is easier math with the amiodarone.
It is easy.
Lido can definitely get a little complicated, especially if you don't have a pump. if you're doing it old school and doing the math in your head.
Yeah, like the Lido clock or whatever.
Right, the
all
Lido
that.
clock.
Yeah.
Yeah. So, and correct me if I'm wrong, but ACLS is actually AHA has come out and said there's really not a difference, right? For a while, it was amiodarone should be first line, then try your lidocaine. It's changed to where it's either or. There's not a first or a second line.
I just took the ACLS farm yesterday, just kind of getting ready for other stuff. And yeah, there's no preferential on it. They actually push both. Because I remember the first time I did ACLS, it was very amio forward.
Right.
And yeah, so now it kind of is falling back down to preference.
Right.
And the real deep dark secret is, do any of these meds ever actually work in codes? So that's a whole nother topic.
Right. A whole nother topic.
Yeah.
No, another deep dark secret is which one makes the most money? Because I specifically, like, I remember in medic school, right? We were amio, and we didn't carry amio where I was at for medic school. We had procainamide, I think it was procainamide and lidocaine, and we just knew you didn't do procainamide because once you pushed it, they couldn't do anything in the hospital for a long time, and the nurses would murder you if you. So we did lidocaine, right? But like amio was what everyone talked about, and so I remember like one of my buddies looking into it and then coming back and being like, well, from what I could see, they look kind of equivalent, but like when I really looked into it, like there was a lot of cost difference and all of that did make a difference. And that, unfortunately, deep dark secret, that does make it a difference in what people use and why.
Yeah,
Definitely.
And I'm kind of like Mike with the pulseless stuff, the cardiac arrest stuff, the cases where it might be a little bit harder to gain information for your bigger picture. I usually probably go with amio.
Do you know you're supposed to use a filter with amiodarone?
I did know that, actually.
I
Because
learned that.
frothy.
Yeah.
I learned that once I got into the flight world.
Me too. I'm like, what's this? And they're like, that's a filter. You've never used amiodarone with a filter? I'm like,
Nope.
nope.
What's your success rate look like?
Is it like an inline filter when you're pushing it?
It's like a filter straw, kind of.
For like drawing it up.
For drawing it up.
Yeah.
Interesting. Okay. Yeah, I had no idea.
So
I've
that's
never
why
heard
we
that.
had those.
12 years on ground. I
Not
never
once.
heard that.
Didn't
I
even
was
think
never
twice
in
about it.
training. I don't remember it at all. And yeah.
Nurses.
I got a little hand slap by a nurse. Yeah.
Have you noticed differences, though, comparatively, if
I
you
haven't
use the
pushed it
straw?
enough to notice a difference.
I'm probably in the same boat.
So this one dosaging typically 300 and then repeat at 150, right? This is again
Pulseless,
ACLS.
yep.
So
It's for
these
your
are-
pulseless.
For pulseless,
dose,
yeah. And then, like you said before, pulsatile VTAC is typically going to be more of an infusion than a push dose.
Usually you're 150 over 10 minutes.
Yep.
Yeah, that was one thing I know from my paramedic school that we never talked about. Like, I knew that you use this for VTAC, but nobody had ever said like, hey, if they have a pulse, it's like, I know I use this, but the actual dose was never explained to me. So it's good to see that what we have here is our local protocols, and that's explicitly stated. 'Cause
Yep.
I had no idea.
And it's the same dosing for the post-ROSC as well.
For the post-ROSC,
Yep.
yeah.
Yeah, so
Especially
just
if you give it as the bolus during a code, you're going to continue. Whatever you give, you're going to continue.
You're going to continue. Whatever worked.
Yeah.
Yeah.
Yeah, which is that's to me that's the easy way to remember it. If it worked, keep going with it.
Keep
If
doing
it
it,
didn't
yeah.
work, then maybe you got to try something different.
Yep.
So then my question would be, because amio has that long half-life, right? So you push amio, there's no conversion, then you push lido. Let's say you make a choice, you change. Are you going to know if it's the amio or the lido or not because of that half-life, how long it lives in there?
Whatever you push last, I guess. But that's
That'd
a
be my answer
whole
too. Yeah.
deep dive into. Honestly, I don't generally give both, so I
Gotcha.
just give one or
that's
the
fair.
other.
One or the other.
I was told by a certain training captain who was like, when you're out of amio, you move to lido. And it's like,
I can
okay.
probably guess who that training captain was.
Don't want to talk about it.
Not the time or the place.
Yeah.
Wait till we hit the stop record.
Yeah,
button,
then we can
talk about it.
chat.
For sure. Yeah. Anything else? Any other nuggets, words of wisdom about amiodarone?
I'd say it's, this is a good connecting topic. Put some good energy towards learning your 12 leads.
Yeah.
Again,
absolutely.
this VTAC, it seems like, is a term that's kind of going away and getting replaced with another broad sweeping wide complex tachycardia. Again, if you just put a little bit of energy towards learning how to read those things, they really are one of our only diagnostic equipment. There's no reason why we shouldn't be pretty dialed on those.
Definitely.
And like we talked about earlier, you just looking at that it's wide and it's fast, pushing these meds that ACLS suggests could kill.
Yeah.
100%.
Absolutely.
Just
I
because it's
totally
wide
agree.
doesn't mean it's VTAC.
Yeah. Yeah. One big thing for me coming from a different school than you guys all went here locally. It was a different state. For students out there, right? Like, don't just like you were saying, right? Like my 12 lead knowledge compared to what is taught here, and Southwest Idaho is pretty progressive and really good with the EMS, which I don't think people realize because it's Idaho, right? Like what, Iowa, what, but the EMS here is really good. And I know coming from going through a California school, like I came up here and I was so outclassed, and I felt it really quickly talking to like you, when I was in FTO, like we were in the same station, and like I would see you, a couple times a week and talking about stuff. And I was like, I don't know anything. Right. Like, and so that might be the case for you in paramedic school, and just with everything. I definitely realized like my paramedic school, our didactic was not super strong, but our skill stuff, we could run calls, like we could run circles around the students that went through the programs here. Cause that's what they were really good at and what they leaned in. And so for paramedic students, try to like have some self-examination of what you think your program is really good at and what it's not good at, and you will have to fill that in for paramedic school. For sure. And for me, 12 leads was a big thing that I needed to like, and there's still some stuff that you talk about that I'm like, sure, Casey. But like I definitely had to like take my time once I realized that was the case. So like, there's so many resources out there now. You have no excuse not to go and learn this information.
Yeah. Never stops learning. You never stop learning.
Never stop learning. Like I said, aside from the glucometer, it is our only piece of diagnostic equipment. The hospital has so many resources for diagnostics. We don't. And so it is the one thing that can give you just a lot of those puzzle pieces towards that bigger picture. Yeah. And what you were saying kind of goes back to that stigma that we kind of got stuck with, is we're better trained, not very educated. And don't get me wrong, there is huge advantage in the training part for sure. But the education part is something that we've been lacking just as a whole, you know?
Cool. I think we have time for one more, and it kind of goes hand in hand with amio. Let's talk about some lidocaine. So another antidysrhythmic, something else we're going to typically use for like a wide complex tachycardia, right? I got it.
VTAC.
So how does this going to work, or do you guys know any significant differences between how this works and like amio works?
Yeah. So unlike amio that has 3 to 4 different channel blocking potentials, lidocaine is specifically a sodium channel blocker only. So you get a little bit more of it's like using a rifle instead of a shotgun, or a Phillips head instead of a flathead, kind of a deal.
More precision.
A little bit more precision, little less potential for big side effects, and significantly lower half-life as well. So those are kind of and just anecdotal experience in it working better. Those are kind of some of the things why I prefer it. But yeah, it's mainly your sodium channel, not mainly, it is a sodium channel blocker. Yeah.
So what does that mean in practical terms that it's a sodium channel blocker? Does that lead you to use this specifically for any certain use cases, or does that does that mean anything, or just knowledge to know essentially?
That's a good question. Let me think about that for a second.
I would say with like your, oh man, I don't know.
Or does that?
I'm trying to think like through the TCA Benadryl, but yeah.
Or maybe flip side of things, knowing it's a sodium channel blocker, is there anything that you shouldn't use this for specifically because of that?
So I think Mike just inadvertently hit it on the head where, with some of these other pathologies that can cause a wide complex tachycardia that's not VTAC, such as TCA overdose, hyperkalemia, a few other instances, those are either sodium channel blockades, sodium channel myopathy, if you will, where if you give this other sodium channel blocking medication, it's only going to make it worse. Yeah, thanks, Mike. That's I'll just feed off you. Yeah, I think that's probably the big one.
Okay.
Yeah.
So essentially, when we're talking about wide complex tachycardia versus VTAC is a cardiac in origin. Essentially, it's something with the heart going on versus something externally that's causing the EKG, what we're seeing, to widen out. Right? Is that kind of what you're getting at there?
It's like a metabolic issue as opposed to a cardiac issue. VTAC is generally a cardiac, a ventricular issue, whereas a slow, wide, complex tachycardia that we're talking about, this clean kill, right? It's some sort of metabolic issue causing these changes in the action potential and the sodium channel potassium pumps that's going to cause your whole QRS to widen. And so if you give certain medications, it's going to cause it to widen more.
Yeah.
It's kind of a simple way of explaining it.
Yep.
And then so practically real world, this is why it's important, right, to know contraindications and to do a good thorough assessment.
Yeah.
You need to know.
And to know that 12 lead
Yes,
backwards and forwards.
absolutely.
That's huge. Yeah.
And are there some things on the 12 lead that you can differentiate, like a
This is going to
VTAC?
go down a rabbit hole.
I mean, we got the guys to talk about it if you guys are willing to talk about it. Like, is there anything that you can really jump, like, easy stuff for students to, like, here's my method, here's what I'm looking for to really hammer down that this is a VTAC versus something different.
Right. Yeah, so there's a few things, a few relatively simple things and a few more complex, deeper things. And it's important to note that 12 leads are never black and white. Just because you see this, it doesn't always mean this, right? So you want to look for multiple things that help you confirm or rule out what you're looking for. So some kind of big things that I like to look for, at least on the relatively simple side, I like to look for extreme right axis. That's a big one. What direction your AVR complex is going. In any normal functioning electrical system in the heart, your electricity should be going down to the left, right? If it's originating from the ventricles in a VTAC, you're usually going to have retrograde conduction back up to the right.
Okay.
So your AVR in a VTAC, usually, again, not always, no such thing as black and white, but usually your AVR will be positive in a VTAC. In any other circumstance, it should be negative.
Okay. And that is because in a VTAC, the origination of the electrical impulse is from down, not up,
From the ventricle,
essentially,
yep,
right?
exactly.
And so we're seeing it
You're seeing it
flipped.
go back
So
up.
yeah, it's
Yep.
like essentially the normal electrical conduction is going this way.
Yep.
If it's ventricular in origin, if you think of where all your leads are, AVR is looking right here.
Down.
V6 is down here. So yeah, if it's your ventricular in origin, your electrical conduction is generally going back, like retrograde, as Casey's saying.
Quick pro tip just on reading some of those things and looking at whether your complex in your 12 lead is going up or down. Super simple. If the electricity is going towards a lead, it's going to be positive. If it's going away from a lead, it's going to be negative. And that can serve you really well in kind of identifying where things might be originating from. As long as you know your anatomy of your heart and which lead looks where. So those are kind of the axis, the AVR, and they're almost kind of the same thing.
Yeah.
There's some R wave progression abnormalities, and this is getting into a little bit deeper stuff. R wave progression abnormalities. There's something called S nadir, usually in your precordials, your V1 through V3. I won't get super deep into that because it's kind of complicated to explain.
We need a 12-lead podcast.
I would love a 12 lead. Yeah, just in front with the whiteboard. But I would also throw out just another reference. Life in the Fast Lane is a fantastic resource. If you don't like opening up a book and you just want to search by subject, it's got diagnosis from A to Z. It's got all the basics from anything to measurements of each part of the complex to the craziest, deepest stuff that you could ever wish to learn about.
They have
great
like
resource.
100 cases where you can go through, and this is what I did when I was out of paramedics, because you need to learn your basics, right? And sometimes this gets really into the weeds a bit, but once you're past your basics, like Life in the Fast Lane is an amazing resource where you can go and test yourself, and then it'll give you the answer and explain in great detail why. It's so helpful with 12 leads.
That's a free resource.
Free
too,
resource,
right?
yep.
Yeah. And actually, I was going to ask you if you had any good resources for
Yep.
people that want to learn this, because this is definitely beyond medic school knowledge.
And
for
EMS
sure,
12 Lead is another good website. So Life in the
EMS
Fast
12
Lane and
Lead,
EMS 12 Lead are probably the two that I've used the most. And then just social media now is so heavy with all these little short. You have to be a little careful because anybody can make a social media post about whatever.
Or a podcast.
Or a podcast, yeah.
Podcast, yeah.
But I feel like some of these like true websites are ECG blog. I forget the guy's
ECG
name.
blogs, yeah.
It's called ECG. Something's
That's
Smith.
Smith's
ECG blog.
Yeah.
It's a very good one.
That one, Shade Tree Cardiology, who's got a big presence on TikTok right now. Him and another dude put out a book, and I got to give that a little read through, and it's actually very good as well.
So bringing it back to lidocaine, right? We kind of
Lidocaine,
talked
yep.
about the how it works, right? All of that. So indications, kind of be the VTACs, right? Is what we're going to be using them for. I don't think there's any really like off-brand kind of stuff for lidocaine, right? Maybe and this would be different, but lidocaine would be for like an infusion in like a conscious IO. You might, use lidocaine there, but I'm trying to think of anything else that might pop up on like a drug sheet for.
They used to teach it with like head injuries and pre-intubation,
Right.
and that kind of obviously it's been
That's myth
debunked.
busted. Yeah.
But malignant PVCs is still in there in a lot of sheets, but I think that's kind of been.
I still use it for that.
Do you? Yeah.
Symptomatic.
Well, okay. Yeah, that's fair.
Symptomatic,
Like
right.
like a Bigemini or something like that.
Bigemini, Trigemini when they're syncopal or damn near syncopal.
Yeah.
I do still like Lido for that. Yeah, really any kind of, anesthetic type deal. Use it for like, if we have the time, do it for like chest tubes or finger thoracotomies. I'd actually be curious. Do you like it for IO?
If I remember and they're conscious, yeah, I will give them a little thing because it's usually in the IO kit, and so you really have no excuse to not give them a little bit of something. Right. But to be fair, I think 90% of my IOs I just go saline just because it's easy.
Yeah, and there's certainly room for some moral and ethical debate here, but I've actually found really good luck with not using it because usually when you put an IO in, we are damn near death's doorstep, right? And again, morals and ethic discussions aside, a little spurt of pain can do wonders for some crashing vital signs.
Yeah.
So I got a story. I think it's maybe the only IO I have ever done on a patient with a pulse.
Right.
It was actually down the street from here. Maybe you just have a different threshold for me.
I think probably. I'm lazy.
You're just that good at it.
Apparently so.
That bad.
But yeah, like a grocery store right down the way. Got called for a lady that was like unconscious in the front. We get there and we load her in the back. And maybe I've told this story on the podcast. Sorry if I have. But we get her loaded up in the back and she's like GCS of like 3 or 4, right? But there's no like obvious stuff going on that we could really account for. I think she was a little hypertensive, but nothing like really obvious. Sugars were good, all that stuff. And, so we're start transport code 3, looking for an IV, and it's me and a fire medic who used to work with us. You guys, we'll tell you his name later. You guys will know him. It'll be funnier if you know who it is. And so we're trying to start IVs. We can't start IVs. And it's like, well, we got to get some access. So let's do an IO. And so get it set up. I drill her, no response whatsoever. And the other guy's like, well, what do you think about some lidocaine? I was like, dude, we didn't get an eye flutter or anything. Like I pretty critical. I don't think it's necessary to do it for this patient, right? So, she was a little hypoxic because she had an under breather on. So I go and I push the saline flush. 2 seconds later, she sits up and she starts screaming at us, and she's like ripping the mask off her face, and she's like, "You're trying to kill me! They're trying to kill me!" So that little pain response woke her up for about 30, 45 seconds until she went, "Ah!" And then I swear it was like I felt like I was in a movie. We both look at the patient, look at each other, look at the monitor, and she's like, I think she might have gone right to asystole, but it was something not good. Right. And we like looked at each other, looked at each other, and I swear in my head I heard wah wah, and then like he jumped on compressions and we started, and she ended up having like a massive head bleed or something. Right. But yeah, the one time I've done it, it gave her that response, which killed her.
Bring 'em back from the
pathology
dead.
is very similar to like a push dose epi.
Yeah. Yeah.
It can.
Probably that last catecholamine release the body had.
Yeah, so different strokes for different folks,
Yeah,
and what
right.
you're gonna do, I guess, a little bit. That's my experience.
I think there's something to say about they're trying to kill me and then her coding. I'm just going to put it out there.
What was it? Yeah. Did she say anything before she died?
it was
maybe nothing memorable.
a bit prophetic, I guess. I guess. So yeah, dosaging. It could be pretty different. Easy to look up dosaging.
Yeah, this one's a
Yeah, follow your
complicated
protocols
one.
on that one.
Yeah,
It gets a
follow-
little deep.
It
If
definitely
you have
can.
a pump, use it.
Yeah.
Yeah.
Don't try and
Learn how to use your pump.
don't try and trench medicine it.
Yeah.
Like the old guys like me and Casey used to have to back in the day.
Back in the day.
So we've covered both the antidysrhythmics. Do you guys have preferences on which one you use for what?
It sounds like not amio in general.
Yeah.
It's
I think
kinda what
amio I
hearing.
use in a code, and I use lidocaine for everything else. And it's not necessary. There's really not I'm not super critically thinking on that one a ton, except for in certain cases, like we talked about with like the TCA overdoses, which we were talking about before this. We've
Right.
actually run on quite a few. It's a lot of Benadryl and TCA overdoses that I've done in the last year, and we really were treating the cause of that right more than we're treating the cardiac effects. I'm giving more of like the bicarb and the ventilator type stuff to kind of offset the metabolic acidosis from that. So it's really not even using lidocaine unless you are to the point where they're totally crashing. So
Right.
I would say lidocaine, I guess, for those, and amiodarone for a code. But in all reality, you're treating the origin of what's going on more than you're just giving the cardiac medication.
It seems like a lot of providers are mostly on the same page with like my amio's my code drug and Lido is going to be my VTAC with a pulse just for honestly ease of administration.
Yeah.
Yeah, and I think it's just coincidental luck that it again, in a code situation, it's harder to, maybe it's easier to go with that shotgun
Yeah.
approach
Yeah, especially if you don't know what's going on.
because you might not know what's going on. So it might be beneficial to hit all of those channels. Whereas in they're still awake, the pulsatile, you can ask some of those questions and you can
Right.
dial it in with
Yeah.
just the one channel blocker.
Makes sense.
Any other words of wisdom on lidocaine? Any other thing you guys are running through your head before you give it? Anything you're thinking about? Contraindications?
I mean,
anything
before
like
you
that?
give anything, obviously checking with your partner and checking, doing your medication cross checks and all that. Just a
Yeah.
general, moment. But no, I can't think of anything necessarily.
Yeah, and I mean, all these contraindications are again for bradycardic
Yeah.
issues.
Yeah.
you know,
Don't give it to
like,
bradycardia.
Don't give it to bradycardia.
Imagine that.
Yeah.
Adam Stokes and your high degree blocks. Yeah, but that's about it as far as Lido and Amio.
Right on. Any other general words of wisdom to share with the audience that's listening?
I think we pretty well covered it.
Yeah, I think so. We'll see if we can't get those links to that video and that website up on the screen.
Yeah, we can
and
definitely put those in the description on
those are-
YouTube.
Yeah, I encourage anybody and everybody, I don't care what level you are, to go watch that video and use that
Yes.
resource.
Yeah, I've always said, act within your scope of practice, but know above your scope. Your knowledge should be above your scope of practice.
It's
so,
a good saying. Yep.
Yeah.
Yeah, agree. And then, especially, I mean, we generally do the BLS level stuff for EMTs. If
Right.
you're listening to this, maybe you're an EMT, and this can be really helpful. We are far from perfect.
Yeah.
And having an EMT partner that's knowledgeable, even if they're knowledgeable enough for me to bounce ideas off of, is so helpful out in the field.
I've had so many EMTs save my butt. I mean, the saying goes, paramedics save lives, EMTs save paramedics.
Yep,
Like,
for sure.
EMTs are an invaluable part of the team.
Yeah.
Nurses save them all.
That's right.
Yeah, as told to you by a nurse, I'm sure.
Yeah. Cardiac ICU nurse. I'm just kidding.
Cool. Right on. Well, thanks for being here, guys. I really appreciate you guys' time. I know you're busy. Well, not the guy that's hurt and currently grounded for a little while.
Yes. I'll be out for a bit.
But yeah, we'll have to do this again. And yeah, if you're watching, listening, we plan on making this a recurring thing to come in and start talking about some ALS level stuff because it seems like people want it. So yeah, thanks for checking it out. Hit subscribe, hit like, all that stuff, and we'll see you next time.
Thanks for having us, guys.
Thank you.
Wade finger guns every single time.